I'm Jim Erickson, CFO, and I head up our marketing group with Monteris here, and I'm joined by a couple of my colleagues from Monteris here, Jennifer England, who leads up our clinical organization. And look, we're really pleased to have Dr. Abel from UPMC Children's. He's the surgical director of pediatric epilepsy surgery there, and has been a NeuroBlate user with us for the last couple of years. And has a breadth of experience of how he's helped to build the program there around LITT and its uses. And what we're trying to do with this is to create a platform for discussion. So we're hoping we continually hear from our users that there's a desire to hear from other people and share experiences around LITT, its uses, its fit, and in across a lot of disease states. Today we're going to be talking about epilepsy, and specifically some pediatric epilepsy. And so feel free to jump in with questions along the way. We're hopeful that this can be a discussion, and we're going to do it around a case review, but that's really hopefully just the platform to ask questions, discuss, and share information. So with that, Dr. Abel, I'll turn it over to you.
All right. Thank you very much. And thanks everyone for joining us this morning. It's an honor to get to present some of our work to you. And I really hope this can be a discussion rather than me just presenting cases. So I trained at the University of Iowa for my residency. And then before I started using LITT, most of my experience with epilepsy surgery had been at Iowa, Grenoble, and then Toronto at Sick Kids. And so actually, most of my stereotactic experience was with ablation experience was with thermocoagulation rather than laser ablation. I did a few cases in Toronto before I came to UPMC, and then kind of started our program here at UPMC when I arrived here. And so that's just a little background on where I come from. And I've been doing this I started here about 2 years ago, and we've been doing laser ablation for about a year and a half, actually. So a lot of the outcomes are very preliminary, but I'll show everything that we have. There's a disclaimer slide. Do you want me to read this, Jim? No, okay. My only disclosure is that I'm a consultant for Monteris Medical. So this slide is very busy, but before I go any further, I just wanted to show some outcomes. Basically, this is like an overview of everything we've done with laser ablation since I got here. We've done 19 ablations in 17 patients. One patient had a neurologic deficit afterwards. That's a patient who had an insular ablation. It was transient and got better. Otherwise, we really haven't had any other complications. The outcomes you see here are very early because most patients don't have a year of follow-up yet. And I have an overview of some of our outcomes on the next slide that are category specific. So we've done 4 mesial temporal ablations. 2 of them are seizure-free and a year out. The other 2 are improved but not seizure-free. One has gone on to have a redo laser ablation. And the other one will probably go on to have a temporal lobe resection. We've done 3 insula-opercular ablations. One patient is seizure-free. One patient is greatly improved, but has had a couple seizures when they've missed meds. The other patient had 0 improvement at all and will be coming back for a resection later on. We've done 5 LITT callosotomies. 3 of the 4 have improved significantly in their target seizures, which in 3 of the 4 cases were drop attacks. The patient who did not get better was a patient where the target seizure was bilateral tonic seizures, and those did not seem to get better. And then we have one of the LITT callosotomies was done last week, so there's no use in reporting the seizure outcome. We've done 3 extratemporal non-insular ablations. 3 of them have improved. None of them are seizure-free. One of them is coming back for a resection. One of them had a redo laser ablation, and the other one will eventually probably have RNS because it's a motor cortex focus. We ablated one DNET, and that patient has done well. They continue to have seizures because they had their DNET was in the setting of, they had focal epilepsy from their DNET in the setting of a genetic generalized epilepsy. They went on to have centromedian RNS for their genetic generalized epilepsy and have had improvement, but it's quite early. And then we have one amygdala ablation in the setting of bitemporal epilepsy where the patient was seizure-free for about 6 months, but is now having breakthrough seizures and will go on to have bitemporal RNS. Any questions about that before I go on?
So I have a couple of these that I've done their ablations and they're still having seizures. How do you decide then, what you offer after that, RNS or a repeat ablation versus temporal lobectomy?
So I can say we evaluate it on a case-by-case basis. So in the case of the temporal DNET, this was a right amygdalar DNET that we ablated on the second to last patient listed there. This is a patient where we suspected they had genetic generalized epilepsy, but when we washed out all their AEDs and a focal pattern emerged on some of the seizures, and so we thought it was reasonable. So we did a bitemporal SEG implantation and found out that that some of the focal seizures arose from the tumor. And so I then did a stereotactic biopsy of the tumor, found it was a DNET, and then ablated the tumor. But I think in this situation, we knew he had a more generalized problem. And so rather than any additional treatment of the temporal lobe, we just went straight to centromedian RNS because the family was not willing to consider vagus nerve stimulation. They had some bias against doing vagus nerve stimulation, and our institution has experience with doing centromedian RNS for generalized epilepsy, and so that was the next thing we offered them. But for example, in one of the extratemporal patients where we did I did a posterior SMA ablation. I think part of the reason her ablation was unsuccessful is because she had rapid spread to primary motor cortex. And so that's a situation where rather than ablating primary motor cortex, I would put in motor cortical RNS. And I definitely wouldn't consider doing a resection unless her epilepsy got a lot worse or a lot more disabling. For the mesiotemporal ablations, there's one of the patients who improved but was still having auras. But her auras were disabling. Like she would have an auditory aura and feel this really profound rising sensation. And she would have to sit down and it would stop her from what she was doing. But she wasn't having full seizures anymore. And so I just thought she had some residual hippocampus. And so I did a redo ablation with the side fire and completely ablated the hippocampus and whatever was remaining of perihippocampal gyrus. And her auras went away after that. But she was language dominant. And so I thought that was a better, in high functioning. Her IQ is above 100. And so I thought, Dan Drain has some data showing that you can preserve naming function with laser ablation versus doing a language dominant temporal lobe resection. And so that's why we offer that to the family. So it's really, this is just to illustrate that at our center, it's done on a kind of a case-by-case basis, and we don't really have a protocol worked out, but it's really done based on what we think is going to benefit the patient and improve their quality of life.
Thanks, that's helpful. I have some, it's hard when you have these. I've thought a bit about, going straight to your temporal lobectomy after you have a failed, or not failed, but I mean improved but not seizure-free temporal lobectomy or temporal mesial temporal sclerosis case. But then, going back for a laser ablation, I guess that using the sidebar I think is a good idea because you can tailor your ablation a little bit better.
Yeah, I found the side fire is pretty useful for doing these mesial temporal ablations. The first case I was going to present, this is a temporal lobe epilepsy case. This is a 11-year-old boy with a history of non-accidental trauma at 3 months of age. He came into clinic with drug-resistant post-traumatic epilepsy. He was on 2 medications. Because of his injury, he has a right hemiparesis. He's had multiple previous surgeries, including a titanium mesh cranioplasty that was done at a local hospital. And for that reason, he hadn't been offered epilepsy surgery previously, and he was actually referred to me for vagus nerve stimulation. His phase 1 evaluation suggested his epilepsy was focal. And so I discussed the option of either doing vagus nerve stimulation with the family or doing a phase 2 evaluation with SEEG to try to further localize his seizures. And you can see here his titanium mesh cranioplasty and some of the lesion from his previous injury. We did a stereo EEG evaluation. The schematic on the left shows where we placed electrodes, and we had to use obliques in the parietal in posterior superior temporal area, given the presence of the mesh. His seizures were localized to the left hippocampus with late spread to the temporal pole. And so in this situation, we offered this is a left mesial temporal ablation. And he's been seizure-free for over a year now. And so the rationale for choosing laser ablation in this case was that it would have been difficult to do a craniotomy given his surgical history. His seizures localized well to the left hippocampus and spread from the hippocampus very late in the seizure. And so we thought laser ablation would give him a good result without having to go through a bigger surgery with a revision of his cranioplasty. Any discussion or thoughts on this?
Yeah, I think that's a great point about the previous craniotomy. Obviously, trying to avoid going through that. And were you going to plan your trajectory through native bone, not through the mesh? Is that what I was hearing?
Yes. So the trajectory was done. Can you see my mouse on the screen?
Yeah. So
the trajectory was planned posterior to the mesh, and it was possible to use a very standard mesial temporal ablation trajectory because the mesh, as you can see, I guess it's better to see on the AP, but doesn't go all the way back to where you would normally typically put in a mesial temporal anchor bolt.
Yeah, that's a great point. Have you ever tried putting either stereo EEG or laser fibers through either a mesh or a prior cranioplasty, a peak, or anything like that?
No, I haven't done that, and this is the one situation where I've encountered it for either SEG or for laser ablation, but I probably would try to avoid it. What about you?
I did it once during fellowship, and it had like a small, like asymptomatic extraaxial hemorrhage associated with it. But it was the kind of thing that we obviously tried to avoid a lot because of the scarred in tissue. It made it that much harder to target and that kind of thing.
Yeah.
I only did it once during fellowship, in my experience. But that was actually going to lead me to another question, a little bit separate, but I'll save it for later once you finish this case.
Okay, this case is. I was going to move on to my next temporal lobe case. If you have any other questions.
Well, yeah, sure. The question I was going to ask was, in your experience so far, have you done more LITT for cases like this that were a previous craniotomy, whether a suboptimal outcome or just a previous defect, and so you were taking advantage of the less invasive LITT to avoid a redo craniotomy, versus maybe a case that hadn't had a previous craniotomy, that you might favor LITT up front with the craniotomy as your backup. So have you noticed any preferences for LITT up front and craniotomy backup versus LITT used for fallback after a craniotomy and resection was unsuccessful?
Yeah, that's a great point. That's definitely something that we consider here, because a lot of a substantial subset of our patients are patients who have had grids before and have had resections, but are still having seizures. And so I'll often discuss the challenges of doing a redo craniotomy with the families when we're having a discussion, and we have one case where the reason we did laser ablation was for that very reason, and that's one of the extratemporal cases where I think they'll probably go on to have RNS later on, because she had early spread to her motor cortex also. But yeah, that's definitely something that we consider here, because I think it lowers the risk. And I do tell the families that until the paper recently came out in Epilepsy, at least I became aware of it last week, showing about a 30% seizure freedom rate after extratemporal ablation. I think it was from Emory, and it was written by their fellow. But until that paper came out, I didn't know what to quote the families for extratemporal ablations. And so what I had told them is, the lesion is a little bit better than thermocoagulation, bigger than thermocoagulation. And we know that the seizure freedom rates after thermocoagulation are about 15 to 20%. And so I would tell families it's going to be between 20% and 30%. That was my best guess. And it turns out that was probably about right, because that's what the Emory paper, that's pretty close to what the Emory paper showed. And they did their extratemporal ablations based on seeing low voltage fast activity in a very narrow area with late spread. And that's kind of what we were doing also, in the exception of this one case where the morbidity of doing a redo craniotomy was really high, given the previous grid and partial resection. But yeah, that's a great point.
I had one more question, Taylor. How you doing?
Good. How are you?
Jerry. So this case looks like there's a lot of atrophy and cephalomalacia much further back. So have you found MEG, helpful in these post-trauma cases, to try to localize or at least target your SCG? What do you think about that? Well, it looks like a lot of the encephalomalacia goes also way back. Occipitally, you can see a lot of atrophy, and I can't see the whole scan, but I know you localized it to the mesial temporal lobe, but I'm just curious if you found MEG helpful. We've used that a lot post-trauma to try to localize these dipoles. What do you think in terms of that utility?
I think MEG is very valuable, and in Toronto they used it in every case because they had really good access to it. At our center, we have to send patients over to the adult hospital, and so also my view is SCG is safe enough where if you have a hypothesis already, it's reasonable to do SCG in the absence of MEG. So at Pittsburgh, we've reserved it for cases where we're having difficulty setting up a hypothesis after FTG PET and after ictal SPECT. If we still need more information, we'll send them for a MEG. but we have a lower threshold for doing SCG prior to MEG, maybe partially because they have to go to the adult center to get it done. But I do think there's a lot of value in doing MEG, especially at experienced centers. And when we see a MEG cluster, we definitely put electrodes there. But that area in particular, in this case, was really difficult to cover because of the mesh. And so you can see I did extra obliques in places where I normally wouldn't do it, just to try to get coverage of that, of those areas. And frankly, if we didn't have a really good onset with the seizures, this lateral area here was not adequately assessed by SEG, and so that's something that certainly was missing in the evaluation and would have come into consideration if we didn't have a good seizure onset. This is a second temporal lobe epilepsy case. This is a 9-year-old boy with drug-resistant epilepsy and right mesial temporal sclerosis. His semiology was not consistent with MTS. We thought it was possibly neocortical. He was on both two anti-seizure medications. So because of the suspicion that he was had potentially neocortical temporal epilepsy with secondary mesial temporal sclerosis, we did an SEG implantation, and we found that he had simultaneous onset in both the hippocampus and the temporal polar cortex, similar to what's described in Stefan Chabarde's 2005 manuscript in Brain, where they describe the temporal polar phenotype of temporal lobe epilepsy. There's no evidence to actually support this practice, but it's my view that if they have onset of epilepsy in the temporal pole simultaneous with the mesial structures, it is probably better to start out with a traditional corticoamygdala hippocampectomy rather than a laser ablation. And so we did not offer, after a discussion in our epilepsy conference, we did not offer a selective mesial ablation to this family. We did a traditional corticoamygdala hippocampectomy, and he's been seizure-free for, I think this case is 6 months. I actually just saw him in clinic this week. I think the flip side of our logic here is that we just don't know. It could be that you do a mesial temporal ablation for these patients and they do just as well as patients who have onset in the hippocampus without early or simultaneous spread to the temporal pole. But that's just something we don't know. And my logic is if the temporal pole is involved early in seizure onset, it should be included in the resection. Any questions or thoughts on that? And what have other groups been doing in your own practice?
I would probably on this one, I would offer them both, and because I can save the surgery for a rescue. So I think it's fair to try laser first, and if that fails, then you do a traditional. I mean, if that's, I would give them an option. We've had families choose just because of the lower invasiveness, see if it works. If it doesn't work, then, I mean, you can always come back and do the full craniotomy. I feel like you can, it's a fair shot. I don't know. I mean, you just have to, I think I usually give them a little bit of a percentage that is unlikely. Like I wouldn't give them a high percentage. I would just lower it. But I think, when we have a shot at them with laser, I think we sometimes give them an option for a laser with the idea that there's a higher chance that we might have to redo it with a full, but then we would come back and do a traditional if they want to. Some of them will just, I would probably favor that I would get them better seizure freedom with it like you did, and then see how they respond. But I don't know what other people would offer, but.
Yeah, I agree. I think the higher functioning the kid, it seems like we're always more minimally invasive. If the kid had such severe disabling seizures and the neuropsych was so poor with, the IQ was low, we probably would be more aggressive, with that kid. But, a very high functioning adolescent, and they would probably choose a laser first, I think. But I think it would depend on the neuropsych a little bit, just to see if it, make sure it matched that right side. We're always so worried about kindling in the left side. As we're doing so much more monitoring now bitemporally, and we're picking up seizures with the RNS, or at least spikes on the other side. So I think I'm a little more sensitive to that. I probably would choose laser first in a very high functioning kid.
What is your experience in doing resection or surgery after a LITT?
So maybe someone else can speak to that, because I've not had to do a resection yet in someone who had a laser ablation previously.
I've done one, and it was a little bit more stuck to the pia. So when you're kind of deep, getting out the hippocampus and that, I did found that it was a little more kind of adherent, a little bit more difficult, but it went fine otherwise.
Yeah, I agree. We've done it a few times. So yeah, it does adhere a little bit more. So it's not as nice to peel it off the pia. Depends on whether you like to use the CUSA or not. One of my partner doesn't, so it's a little bit harder. With the CUSA, it works okay. You just have to probably be a little bit more than 20/20, but it does adhere. It's definitely more adherent than usual. So, but it works. It's not that terrible.
Yeah, I think that's a great discussion. I think this happened to be this is a very high functioning boy. He gets A's and B's in school. I think it probably would be reasonable to offer a mesial ablation, but in this case we did not. So I'll move on to the next case. This is an example of a LITT callosotomy. This is a 6-year-old girl with Lennox-Gastaut syndrome. She was having 20 to 30 seizures a day, 10 to 15 atonic seizures per day. She was on 4 medications. She was referred for vagus nerve stimulation. Given the frequency of her atonic seizures, we discussed performing a simultaneous LITT callosotomy at the time of vagus nerve implantation. And the imaging here shows her callosal anatomy. She has a thicker corpus callosum, which I think makes a laser ablation of the corpus callosum a little bit more straightforward. This is how we planned the trajectories. I've done 5 of these. I usually do I've done 2 attempted complete callosotomies, and I tried to do the entire corpus callosum here, but you can see here there's going to be one area that we're not going to be able to quite get. So I usually do a splenial trajectory, a GNU trajectory, and then a trajectory into the body. This is our workflow that we use here. I show the Atama board here, but I now use the Lexel frame for all of these cases, especially for callosotomies. I found that when using the ROSA, there's less trouble co-registering the O-arm CT if I have them pinned in a Lexel frame. The Lexel frame gives me a little bit more flexibility about where I can place the bolts. So we do I put in bone fiducials, I do an O-arm spin, I co-register to the plan in the ROSA, and then we use the ROSA to place the anchor bolts. This is a patient who had 2 body trajectories and then a GNU and splenial trajectory. And this is how the ablation turned out. You can see the sagittal here that we were able to get most of the corpus callosotomy completed, but we left this little area behind. And this is a coronal video that I hope goes through well. You can see the ablation there. Oops. And She was discharged on post-op day 3. She did require rehabilitation for PT, OT, and speech. She needed a temporary NG tube. She's now 6 weeks out and has not had an atonic seizure since that time. She now also has some days where she doesn't have any seizures at all. Her family is pleased, so I'm happy with this outcome. Any questions, comments, or discussions on that?
Did you do the VNS as well at the same time, or how did you decide for or against that?
So, because of the way they've done things here at Pittsburgh, I did the VNS simultaneously, and it's kind of one of those things where I'm newer here. That's the way they've done things for many years. I think my preference would be to do the callosotomy first, give it 3 months, see how it goes, and then do the VNS. And the other thing I want to bring up with that is there's never been a clinical trial of callosotomy because of how invasive it is, most likely. I found that families are a lot more receptive to LITT callosotomy, and maybe this is an opportunity where we can finally do at least a small clinical trial that compares callosotomy to VNS for atonic seizures. I think it would still be extremely challenging to do. You'd have to get multiple centers involved. But we do them both at the same time in most cases here in the 5 that we've done. But I think it would be very reasonable to do them sequentially and kind of see how it goes. It would probably be more cost effective that way, especially if you're doing the callosotomy first.
How many fibers did you use? We use Visualase. So for Visualase, it's a little annoying because you have to use 3 different fibers, or 4 if you have 4 trajectories. We've been toying with 4 trajectory, but that's 4 laser fibers. So we're talking a cost to the hospital of over $50,000 in laser fibers. I don't know if Monteris has a different, then you start saying, well, I have a traditional corpus callosotomy, it takes me 4 hours, $3,000 craniotomy versus a $50 in hardware. And potentially, we don't know if it's as effective or not. We have pretty good results with our full corpus callosotomies. But as you said, the patients, once you offer it to them, they want it. We have 5 in this from July onwards coming up corpus callosotomy. 4 of the families wanted to do the laser, even though we said it's a newer thing. 1 elected to go with the other one. I kind of told them, do you like Teslas or BMWs? You like to do the new technology, or you want to go with the tried and true? But anyway, how is it with Monteris, and what is the cost of them with Monteris?
So I have to admit my ignorance. I couldn't tell you about the cost, but I would say that. So, for example, for this particular case, it was 3 trajectories, but we used the same fiber for each trajectory. But going back to this case here, which I don't have like an actual presentation of this case. This is the one that we just did, and these trajectories were longer, so we needed to use a different fiber for these 2 than for these 2, and so we had to use 2 fibers for this case. But it just depends on the trajectory length. And I usually do, in the 5 cases I've done, unless it's like a completion callosotomy, I've done 3 or 4 trajectories if I'm trying to get the whole thing.
Yeah. Yeah, I wonder how. I'm waiting for the hospital to start yelling at us for doing this.
Yeah.
I think it also depends on what your MRI setup is. If you have an intraoperative MRI where you can easily place and remove fibers, and you're swinging the scanner over the patient, versus if you're putting the fibers in and then traveling to a diagnostic MRI, then putting new fibers in and taking the old fiber out sequentially is very, very painful. So I think some of it depends on what your hospital setup is. Taylor, what do you have are you intraoperative MRI, or are you placing them in the OR and then traveling?
So we do it in the intraoperative MRI. So our scanner is just connected to the OR. So we place the anchor bolts, they wheel over to the MRI. We take the Lexel frame out, wheel them over to MRI, just through this door that opens up. And then we just place each individual fiber in the scanner.
What did you think about the size of the fiber? I guess you haven't done anything with visual ACE, so you're using all the Montefiore fiber. What do you think about the size of the fiber with respect to the size of the corpus callosum?
So actually, the next case I'm going to show is a case where is another callosotomy where I decided to not use LITT, and I used the smaller probe and the diffusion tip, which is smaller, and I've not had problems with it. I've gotten more comfortable doing thinner corpus callosums recently. But for example, this is a case. Oops. In this case here, I just didn't feel comfortable that I would probably hit the target, but the ablation would be so thin that it would be kind of tricky. And this is a family where this is a 2-year-old with Lennox-Gastaut. They were having 20 bilateral tonic seizures a day. Because of how thin the corpus callosum was, I did not offer a LITT callosotomy. We did this open. But what would you have done, and what would you have all considered here?
I would have done the same. I think if you're in that paper I wrote, we put a figure that looked almost just like this, where we said this is not a good candidate.
Yeah.
I agree. I would have done this open. I think you probably would have needed 4 lasers in this one too, just based on that body of the callosum is so curved. It would have been really tough to keep in target.
Yeah.
I agree with you.
But it's a high arching.
Yeah. So this is one that is pretty clear. And the other consideration is that at 2, it would have been a little trickier getting the bolts in and head fixation, and all those things contributing make this not a good candidate for laser callosotomy. Any other thoughts on that?
Yeah. Oh, sorry.
Oh no, go ahead.
I was going to say, I'm curious if anyone's still doing 2/3, callosum anymore. Something we've talked about, for years, and then we've always done these completion callosotomies if it didn't work. But what are your thoughts on full versus 2/3, and who you do it on?
Yeah, I'd be interested to hear what you think also. But what I've done is if it's a kid that's higher functioning, I'll do a 2/3 first and kind of see how they do cognitively and see how their seizures do. If it seems to work, great. If it doesn't, I'll come back and do one of our LITT callosotomies is a completion callosotomy from a patient like that who was high functioning but was just having a lot of drop seizures. And so I tried a 2/3 first. It didn't work, so we did a completion laser callosotomy later on. What's your practice been?
Same. I think, when the kid is so high functioning, you're just worried, right? In terms of what you might, if you hurt that kid's functional status at all. But I must say it's rare to see that. Even though I've completed it, I haven't seen these kids get worse. I think, a historical perspective might be good here, but I guess I'm conservative in that high functioning kid.
That's fine. We've been full corpus callosotomies for, I think, the last 3 years, pretty much. But I think we always talk about the 2/3, like you said, on the higher functioning, but I think we haven't had any problem. They might, the most problem we've had was if you had a little bit of a retraction issues, like those kids, that seems to be more correlated with their length of stay in the rehab. If you had a little edema in retraction versus just having a full corpus callosotomy, I mean, they always, the higher functioning ones tend to stay in rehab a little bit, but they tend to, I haven't seen it. Most families have been pretty happy with the result, I think, even. So we kind of been very leaning towards a full, and I don't remember now doing a 2/3 in a while at Nationwide here. But.
But since I've been here at UCSF, I haven't been doing the epilepsy, but I can say at St. Louis, which is probably why nationwide the same or similar with Jeff Leonard. Those guys had years ago, before I was their fellow, had studied that and found that they had that similar experience where the anterior 2/3 they were doing completions more often and weren't having quite as good a seizure outcomes, and the completes they were having better seizure outcomes and very few disconnection problems. Oftentimes because they're well selected, kind of low functioning patients. They still had the same experience I think everybody's describing is we'll offer the anterior 2/3 if they're very high functioning. And especially now that Matt Smith is doing so many laser callosotomies, it's very easy for him to put in a laser fiber and complete it. But that's what they were doing is almost everything was open, almost everything was complete callosotomies, kind of like what Amar described. When I was a fellow last year, Matt was doing almost all of his callosotomies laser, and he started off doing only anterior 2/3 with laser because he felt there was too many trajectories to get it complete. Now I think he's since transitioned to doing complete callosotomies with laser, kind of like what you're describing, Taylor. But he was just kind of describing it as it's such an easy procedure. You go home the next day. If you need to come back for the completion, that's really easy too. And the whole process of 2 surgeries is easier than 1 open surgery for the complete. So that's what they were doing when I left there last. And I haven't been doing the epilepsy since I joined UCSF. So.
When you were at WashU, I mean, that's exactly why we do it's pretty much out of the WashU experience since we are heavy on WashU because of Jeff. But with the laser full, are they going the next day, are you saying, or are they having rehab? Like, I mean, how are they, the higher functioning? Are you seeing did they see a difference in terms of complete disconnection with a laser versus open on the higher functioning kids?
When I left, they had not done enough complete to compare to the complete open experience. When Matt started doing it, he just started off doing all either completions of prior anterior 2/3 or anterior 2/3 with laser. And so when I left, he hadn't yet done a complete. Now I know he has since then, but I wouldn't be able to tell you the comparison of a complete laser callosotomy versus open complete callosotomy. Of course, the anterior 2/3 were very, very short stay, but.
Okay, sounds good. This is the last case. This is a 14-year-old girl with drug-resistant epilepsy. She has 6 to 7 seizures a day. She has a history of hypoxic ischemic injury at birth, and it had seizures since that time. She's on 3 anti-seizure drugs. So you can see her hypoxic ischemic injury here. The other thing I didn't mention is she had morbid obesity. She was 300 pounds, so it would have been a little more difficult to do a traditional type of epilepsy surgery for her. Phase 1 evaluation revealed biparietal seizure onset, and so we had a hypothesis about where her seizures were originating. We did a right greater than left stereo EEG evaluation that examined the bilateral parietal cortices and the bilateral insula. You can see here her seizure onset zone involved the insula, which is contiguous with her lesion. You can kind of see it here. And so we performed a right insular laser ablation using 1 oblique and 2 orthogonal trajectories, and she's been seizure free for about 1 year. This is a case where, given her comorbidities and also, frankly, the odds that she would have gotten better after a very high risk, or would have become seizure-free after a very high-risk epilepsy surgery if she were to have an open resection. We thought laser ablation would be the best option for her, and thankfully she's done well. Any thoughts or discussions on this case? Thank you. that's all I've got. Any other questions or comments? Thank you, everyone, for hearing my cases today, and definitely feel free to reach out if you have any questions.
Yeah, definitely. Thank you, everybody, for joining us. Great discussion. Hopefully you found it helpful. And thank you, Dr. Abel, certainly for taking the time to put this together and lead the discussion for us. It was great.